Let's start. Hello, everyone. I'm Can Zhao from NVIDIA, a research scientist from NVIDIA. And today I will be honored to host this MICCAI Industrial Talk. Today our speaker is Dr. Enhao Gong, and the title of the talk is Deep Learning-Based Imaging Enhancement, Image Synthesis, and Low-Dose Imaging. Dr. Enhao Gong is a researcher in the field of AI in medical imaging. He is also the founder and CEO of Subtle Medical, a company that specializes in developing AI technologies to improve medical image acquisition, reconstruction, and quantification. Dr.
Okay, you're a little bit breaking, but yeah, I think I start. And in addition, we also invited my colleague Sri Prasad to join. Maybe Sri can just give a quick introduction to yourself.
Yeah, so sure. Thanks, Enhao. So glad to join Enhao today in helping with the talk. So I'm a senior research scientist at Subtle Medical. I did my master's in biomedical engineering from Johns Hopkins University, and I've been working with Subtle for the past about 4 years, and I've been developing low-dose MRI, a deep learning-based MRI technology. Thank you.
Yeah, thanks, everyone. And just quickly go on the outline. So I will introduce a little bit on what we're doing, and maybe start with a few a little bit boring part in just product introduction, general technology introduction, and then I will turn to Srivatsa to deep dive on latest TMI paper. And based on time, I will also quickly go over several other papers we presented at ASSR and ASNR on clinical application of deep learning-based enhancement and synthesis. Okay, so just quickly overview of Subtle Medical. So as I mentioned, we are a company really focused on improved medical imaging from the upstream imaging enhancement. We are a team starting from Stanford back in around end of 2017, early 2018. Right now we have around 80 people worldwide with office places in several countries. And we are really focused on combining the advantage of AI plus imaging physics plus clinical insights on what is really important, and really commercialize, kind of convert innovation into real product and commercialize it. So the team has a lot of experience from the both academic side and the industry as well. And this is kind of the radiology value chain. I think all this everyone is very familiar with. So we really want to improve the AI augmented image generation or image acquisition side of radiology workflow. And starting, I think, several days ago, we found there's a lot of research and clinical opportunities that AI, instead of replacing human beings, can really replace a little bit like a non-AI based algorithm for solving the inverse problem of image generation, image acquisition, image enhancement. And in a way, it's also complementary to downstream diagnostic application that many more AI company or institution has been working on to use AI to improve image analysis and diagnosis and treatment. And we really focus on image acquisition and enhancement, because if you're really looking at the cost, the majority of radiology cost is actually not on the profession side. It's not on the radiologist. It's on the service side. And it is the service, the exam time, that's the bonding time and bottleneck for cost and inefficiency within the network, within the kind of industry. By improving the data from source, we can solve a lot of problems that the downstream cannot solve from data only from PACS. And we converting into really clinical usage, we can really provide immediate financial value to our customers, which are both mostly hospital image centers. In a way, they can serve more patients better. So there's a lot of value to both patient and provider. And so for patients, it's just a better care in general, improve comfort, improve the experience. And for radiology, usually it's better quality and faster acquisition. And for in terms of facility perspective, there's both clinical value and operation value. There's kind of a clear pathway to commercialize it and to really adopt in clinical, because that's the key component. Because a lot of times papers, maybe MICCAI papers, has been the first place and the deathbed of innovation. So we really want to convert innovation into working products that serve patients daily. And our flagship products, Subtle MR, Subtle PET to say, has been cleared almost worldwide. We have obtained 2x FDA clearance, CE mark, with more improvement as the AI products keep evolving. And it's also being supported by peer-reviewed paper and evidence. It can support all the body parts, all the scanner types, and the different type of tracer that's clear for PET usage. And so I think that's helped us to get adoption worldwide with the end purpose to really provide faster, safer, and smarter imaging to the customers. And just a few imaging examples. In general, I think most people are very familiar with is AI-based, better adaptive image enhancement, quality improvement. And what is really key here is, I think that several ends. Data side is for both training and testing and validation, really need to acquire the data that is first, sometimes quite unique and quite rare in clinical settings, because you want a standard care, maybe sometimes even golden standard, really long exam and a state-of-art quality. And also you acquire the acquisition with an accelerated protocol or lower dose protocol, and you use for post-training and validation, you augment for training as well. And for really validation, there's clinical application to show it is not only good looking in terms of some qualitative metrics, but really for some like quantitative clinical task, we can show the result is consistent or even better than standard care. So I think that's how we keep improving our product and keep improving our technology in general, deep learning model with more latest model architecture as well. And I think there are several technology we developed and we'll introduce like on top of MR to enhance the quality and to check the quality and to reduce the MR contrast usage and to even synthesize new contrast from existing scans. So there are several papers we will talk about this. And so one of them, subtle things, I think the second paper will talk about that. In general, we can reduce subtle artifact and improve quality for certain contrast within like spine imaging. There are certain contrasts that actually we show the AI synthesized version is better just because the contrast sometimes have more artifacts or more sensitive to motions, have more lower signal quality. So we really can augment the care with AI synthesis. And Srinivasa will like talk more on enhancement and contrast agent like applications. So this is several kind of series of papers we published since 2018. And we have also got an NIH grant on this with a goal to really taking low dose and pre-contrast image using deep learning involving model architecture to generate an approximation of full dose image. And we show it's not only the general quality, but for several clinical applications, segmentation, etc., we can show the AI enhanced version is actually better. And why we want to do it, because first, contrastations, the dosage has been really valuable because human beings or radiologists want to see the contrast different between pre and post. So in general, they inject certain contrast. But for example, MR is gadolinium based, is a heavy metal, and latest like studies shows it's actually some of them will depose in brain and body, but no one will want a heavy metal kind of a molecule in your body. So I think there's concerns on the safety, and there's also huge volume of usage. So and by reducing dose, it can make it a better experience, safer from both subjective and objective perspective, and can open a lot of applications for pediatric, for certain population. For example, patients with kidney function issues, they often cannot get injected contrast with maybe 10% lower dose. We can do it. And in addition, there are more like environmental findings, like so it's related to the like as ESG type of like topics, right? So so it's also the contrast is also bad for the environment, and they're increasing density find, and most of them actually come from medical imaging. So for all this purpose, we want to reduce contrast, and we show the technology using deep learning based generation can do better job for half dose and even 90% dose reduction, and sometimes I think like ultra like or virtual dose from zero dosage. So some of the discussion will be introduced by Srinivasa in the general image contrast synthesis, multi-contrast synthesis work. And in addition, for like MRI. We're also working on nuclear medicine modality such as PET. So the general idea is to reduce the dosage, radiation dosage here, as well as improving the efficiency. So that can help to serve the increasing demand, increasing volume of radiology imaging. And for sure, all this ionizing radiation dose has been shown not a good thing for patients. And I think in general, faster and or lower dose can facilitate adoption and cost efficiency as well for diagnosis screening with both, as I previously mentioned, an MRI, but also for sure nuclear medicine applications. So we have set a path in general is to improve the image quality and reduce it, enable lower dose or faster acquisition. So the study shows it usually can restore image quality for up to 75% reduction, which means usually clinical adoption we use for full-time accelerated protocol, the sites choose, or can do full low dose. We do have real low dose publication shows it can inject lower dose and show equivalent or even better results. And several studies validated, and for both routine FDG application, that's usually 95% PET used for oncology, but also there's increasing usage of PSMA new tracers and amyloid tracers for Alzheimer's disease diagnosis, etc. And our product has been, or the technology has been shown generalizable for new tracers, some novel tracers that has been developed for very targeted like diagnosis or therapeutic applications. But often this type of image have way worse image quality. And there's also demand for lower dose just because of safety and the longitudinal screening as well. And we can enhance it, and we get to show the work is generalizable across different tracers. Just quickly go over since it's not that technical. And so, yeah, I think in general it's working for different tracers. That's there's a generalizability component. That's we designed the technology with the model to making sure it's working for different body part, different tracers. And in addition to PET, we also work on SPECT. It's a more used, more adopted nuclear medicine modality. We can show for bone scans. We can do it around 4 times or 7 times speed up or faster. That has been published on JNM in 2021. And similarly for interventional imaging, there are a lot of radiation, not only for CAS lab or DSA imaging that's to the patient who is maybe under surgery, but also this radiation dose will have impact to the surgeon, to the practitioner, to the provider. So using AI to improve the quality while making it lower dose for interventional imaging has a lot of applications. And we have making sure this work generalizable, but also I think the technical part is making it more efficient, for sure, leverage a lot of technology from the industry as well to make it faster. Yeah, and with it, I want to conclude. So our technology has been keep evolving with more and more applications using AI to improve medical imaging with a real focus on the upstream image acquisition, enhancement, like contrast generation has been adopted, I think right now, maybe 500 sites, and also partnership with industry leaders. I think the end goal is really by leveraging the customer like footprint and partnership. We really want our AI technology being adopted and help patients daily. So that's really the goal. Yeah, I think that's maybe the boring part, but just a high level overview on what we have do, why we do it. The first paper, or maybe the major paper we try to deep dive is the multi-contrast transformer. That's Srivastava has been lead the work, lately been published on TMI. Maybe Surya, you can take over.
Yeah, Enhao, you can continue presenting. I can, yeah. So thanks. And moving on to the paper, next slide, please. Yeah, like Enhao mentioned, it has been, it's available in early access in IEEE Explore. So folks interested can check out the early access version. Next slide, please. Yeah, So multi-contrast MRI is widely used in clinical practice for various applications and disease diagnosis. The availability, though, of different contrasts may vary due to patient motion during scanning, poor resolution or artifacts, and long scan duration. Missing data imputation is the approach of synthesizing these missing contrasts from the existing ones. Missing data imputation has a wide range of applications, such as motion mitigation, avoiding rescans, and synthesizing targeted sequences for various applications. Next slide, please. Historically, CNNs have been used for missing data imputation, but are limited by certain factors. CNNs also require fixed number of inputs and outputs, which requires exponentially large number of separate models to be trained for different sequence combinations. So CNNs are also unable to capture the long-range dependencies within the input images. Moreover, CNNs inherently lack explainability and interpretability. Hence, recently, vision transformers have been widely explored for various computer vision applications. Next slide, please. I'm sure the well-informed audience of MICCAI need no introduction of transformers, but anyway, I'll give a quick overview. Transformers were first introduced in natural language processing. Transformers were introduced in the language models as a means of long-range attention. Given a query key and a value, the attention is computed as a dot product of the query and key, scaled by the number of features and multiplied by the value. Next slide, please. This was further extended to multi-head attention as a means of self-attention, where the queries, keys, and values were linearly projected h times with different learned projections. Next slide. Using this as the building block, the transformer model architecture was introduced as an encoder-decoder architecture. Transformer is invariant to the order of input sequences, which is really essential for our application. So these sequences are invariant as the positional encoding is injected to the input embeddings. Next slide, please. So from the language world to the vision world, the idea of transformers were extended to images by patch partitioning and linearly projecting the embedding before feeding it to a transformer encoder, like shown in this work. Next slide, please. But there was some computational complexity attached to the previous solution. So SWIN transformers actually completely transformed the world of computer vision by further reducing the computational complexity by introducing two key features: hierarchical feature maps and shifted window attention. Self-attention is computed only within each local window and allows for cross-window connection by using a shifted window approach. Next slide, please. Hierarchical feature maps are simply feature maps at different scales, as shown in this figure. Next slide, please. Combining all of these building blocks together, we formulated missing data imputation as a sequence-to-sequence prediction problem. MMT, as we call it, can take any subset of contrast as input and generates the missing one. The input images are fed to an MMT encoder, as shown in this figure, along with corresponding input contrast encodings. The hierarchical feature maps from the encoder are then fed to the decoder along with the output contrast queries, which produces the output images. A discriminator is also used as a means of adversarial training to guide the end-to-end model training to synthesize realistic images. Next slide, please. Next slide. Yeah. The key component of the MMT architecture is the MMT encoder, which generates hierarchical representations of input images at multiple scales. It's very similar to a SWIN transformer encoded block. It performs joint encoding of multi-contrast input to extract complementary information from the other available contrasts for accurate synthesis. The encoder is designed similar to a unit structure where the downsampling path has two successive encoder blocks and is followed by a patch merging layer. The patch merging layer concatenates the features of each group of 2x2 neighboring patches and applies a linear layer on the concatenated features, which results in 2x reduction in spatial resolution and 2x increase in the feature dimensions. Conversely, in the downsampling path, two successive MSWIN encoder blocks are followed by a patch expanding layer, in the upsampling path. The patch expanding layer first applies a linear layer to increase the feature dimensions by a factor of 2. Then each patch token is split into 2x2 neighboring tokens along with the feature dimensions, which results in 2x increase in spatial resolutions and 2x reduction in feature dimensions. Next slide, please. The decoder progressively decodes the encoded outputs at different scales and generates the output image in a coarse-to-fine fashion, which allows it to consider both local and global context for accurate image synthesis. Similar to the upsampling path in the MMT encoder, two successive M-spin decoded blocks are followed by a patch expanding layer, which doubles the spatial resolutions and halves the feature dimensions. The last patch merging layer performs a 4x upsampling and restores the feature resolution to a h by w height by width by splitting each patch token into 4x4 neighboring tokens along with the feature dimension, which reduces the feature dimensions from 16 times the number of contrasts to the dimension of the contrast. Next slide, please. CNNs, although, are good at extracting local image features. So to combine the best of both worlds of transformers and CNNs, we use shallow CNN blocks for image encoding after feeding the images into transformer blocks in the MMT encoder and decoder. Next slide, please. We use the least square GAN loss term to synthesize realistic images. Label smoothing was also used for training stabilization. Next slide, please. We use the L1 norm between the synthesized image and the ground truth as the synthesis loss. We also use the self-reconstruction L1 norm as a regularizer. Next slide. The total loss is the weighted sum of the reconstruction loss, synthesis loss, and the adversarial loss, as shown here. Next slide, please. For training and evaluation, we use the BRATS public dataset, which has over 1,200 patient studies with T1, T1 post-GAD, T2, and FLAIR, along with the ground truth tumor segmentation for each case. We also pre-process the images using mean normalization and cropping. Next slide, please. These are some high-level implementation details. We use the Adam W optimizer with the batch size of 32 and the given learning rate and the different loss weights. Next slide, please. So this is a key component of the proposed MMT model because we handle variable inputs and outputs at train time. So at training time, the data loader generates a random combination of input-output contrast for each batch so that the contrast encodings and the contrast queries, which are basically some learned vectors, are learned appropriately. The length of input and output can be variable, as you all know that the dot product operation in the attention computation can be done for any number of tokens, because this has been borrowed from the NLP world. Further, for the multi-layer perceptron, used as part of the encoder-decoder blocks, can also operate on a variable number of tokens. Next slide, please. So in the training, 3 different scenarios were handled in both the training and evaluation. Random number of missing inputs, single missing input, and missing input is always T1 GAD, which is a special case, which is the zero GAD synthesis. We use the structural similarity index, peak signal to noise ratio, and the learned perceptual image patch similarity, LPIPS perceptual metrics to evaluate the different models. We used an automatic tumor segmentation algorithm to segment tumors using the ground truth images and the synthesized images to show the model performance on a downstream clinical task. We also used another public dataset, IXI, for generalizability assessment. We compared the proposed model with 2 other state-of-the-art algorithms, MILR and MMGAN, as cited here. Next slide, please. The quantitative results are tabulated here in comparison to other state-of-the-art methods. It can be seen that the proposed model is consistently better than the state-of-the-art models in all missing data scenarios across different data sets. Here are the individual metrics for different combinations of, next slide, please, sorry. Yeah, so here I'm showing the individual metrics for different combinations of missing data scenario for the IXI data set. Next slide, please. So here is individual metrics for different combinations of missing data scenario for the BRATS data set. Next slide, please. Here are some qualitative examples for the IXI dataset. The bit notations in yellow basically correspond to the different missing or available sequences in the order of T1, T2, and proton density. Basically, the sequences available in the IXI dataset. So 1 in the position means the contrast is available during synthesis, and 0 means it is missing. Next slide, please. Here are some qualitative examples of the BRATS dataset. Same bit notations apply. but in the order of T1, T1 GAD, T2, and flare. So it can be seen that as the number of available contrast increases, the synthesized quality improves. So especially in the T1 GAD. So here in the earlier synthesis, there is some lack of information, but as more contrasts are available, the GAD synthesis gets better. Next slide, please. Sorry. Yeah. So here the tumor segmentation performance on the synthesized T1 GAD images. It can be seen that the dye score for MMT is better than that of the competing methods. Moreover, the intricate structure, sorry, I don't know how to make these annotations go away. Yeah. Okay. Yeah, so you can see that the intricate structures of the gliomas and the glioblastomas are restored here reliably in the MMT model, while there is some resolution and information loss in the state-of-the-art methods, which is also reflected in the dye scores shown here in comparison. So, yeah. Next slide, please. Yeah, so here is it's a further ablation study was conducted on the dye score with missing and imputed sequences. So basically, tumor masks were segmented with different combinations of missing sequences, and we found that it had poor dyes overlap. These missing sequences were imputed using MMT and replaced in the input to the tumor segmentation, basically mimicking a clinical task. Here in the particular example, T1 GAD and flare are missing. So here, the T1 GAD and the flare are missing, and you can see that the dye score is really low and there is literally no tumor mask. But when the T1, the missing sequences are imputed here, which is the T1 GAD and flare, the dye score shoots up from 0.052 to 0.947, which shows that the images synthesized by MMT are clinically equivalent. Next slide, please. This slide shows actually the explainability aspect of the proposed model, which is actually a benefit of using a self-attention mechanism like vision transformers. So the middle row here shows that in the particular example of T1 GAD synthesis using T1, T2, and flare as inputs, the T1 image contributes most to the overall structure of the brain. So here it contributes most to the overall outer, the gray matter, white matter structure. But when it comes into the inside of the lesion, T2 contributes some information and flare contributes some more information. And then this T1 GAD synthetic is synthesized. So this basically shows how these three contrasts are interacting with each other and extending, extracting the long-term information to synthesize the T1 GAD. So this, the bottom row here is basically an ablation study. So we have this cross-contrast attention that is part of the MMT encoder. And when we disable this cross-contrast attention and basically collapse all contrasts and make the transformer block to compute the attention without giving the context of the contrast, then the heat maps don't make much sense. And also the reconstruction is kind of lossy in terms of the lesion information. So that basically shows the effectiveness of the different blocks in the proposed method. Yeah. This slide shows that the decoder learns the features in a coarse-to-fine fashion. The earlier decoder layers learn lower-level features as shown in the second row. And the subsequent layers combine these lower-level layers to learn higher-level, finer features as we move down. Next slide, please. This slide shows the percentage of attention scores averaged over all cases. This can be interpreted as the contribution of each individual case in the synthesis of a target contrast. So for example, here for the T1 GAD synthesis, T1 contributes the most information like we saw in the heat map, 53%, and followed by T2, which has 20% contribution, and FLAIR, which has 26% contribution. But this is averaged over all cases in the evaluation set. So it will be interesting to actually see for different cases like gliomas and glioblastomas and other kinds of lesions, what is the different contribution of the input contrasts. So that actually concludes this IEEE paper on missing data imputation. I hand it over back to Enhao.
Thanks, Sri. So yeah, I think in general, I feel that what this paper is, I think there are several contributions, as we mentioned, to transform the multi-contrast synthesis into a sequential, like kind of using transformer to solve this. And I do really, I think I'm looking forward to questions, and the ideas on the attention map. I think is something really good to understand on the contributions. Given the time, I think I can still have time to go over quickly for another two paper, which I think this paper is quite technical, and a lot of validation is mostly technical validation to show a number, right? Number really help to understand what's the contribution for certain contrast and the general as all these metrics. And the next two paper I want to quickly go over is application also on deep learning based synthesis and enhancement, but quite tailored to clinical community on the real clinical validation as well as the some clinical applications. The first one is for a spine MR synthesis. It's just be recently presented as ASSR, which is a spine focus clinical community in US. And so the general idea is we show that this can be applied in clinical settings for deep learning synthesis, which is quite a new thing for clinical applications. And so generally, I think people from this audience, I think everyone knows. So first, AI deep learning can, as several products technology shows here, can enable faster MR acquisition while matching or exceeding the quality of standard care. And on the other side, there are several works from us and other researchers shows deep learning can create synthesized contrast from existing data sets which generate more value. And one key application for spine, we call subtlescenes, is generally framework, and this is specific for multi-contrast acquisition for spine imaging. For spine, there are several contrasts usually. T1, T2 is a routine there. So one contrast called STIR is really you have certain application for clinical indications such as inflammatory applications, etc. That STIR can provide kind of a enhanced T1 plus T2 with fast separation and used for clinical diagnosis. And a lot of clinical diagnosis rely on multiple MR contrasts for clinician to make decision. And on one end, we can, there are several technologies, including solid MR, can speed up per sequence, but also across sequence, we can leverage all this shareable information to improve the quality. And one application we show here is we can use T1, T2 to get better STIR. And it can not only increase throughput, but also improve patient care, patient experience, have less image artifacts, which clinician radiologists really want. And we show it's generalizable, can be applied directly on a DICOM-based vendor-agnostic framework. And so I think one clinical part is here is we do not only just the image review, like quantitative analysis, but also have done multi-center, multi-study, reader study, show the interchangeability in clinical application. And there are several, I think we have 30 retrospective studies, and they're from different manufacturer, different scan model, from really low field to standard field. And we have independent radiologists to review it, and they will be randomized to provide synthesized version or the acquired version to rating. And so it's in a blind setting. And the reader will use this data to identify certain pathology, if it's present or absent, and also rate the image quality, rate the confidence of diagnosis, etc. And so we have show analysis, and the general idea is to assess the interchangeability of providing synthesized STIR versus acquired STIR. So we show there's no significant difference in pathology classifications. And in addition, I think the general is image quality we actually show is a significant being viewed as better quality, just as I mentioned at the very beginning for STIR contrast in real clinical settings, because it's very sensitive to maybe first is lung acquisition. It can be sensitive to the motion and have low SNR. So the acquired version is even for standard care quality is not that good quality. And we can show with synthesized version by leveraging all this data we have from T1, T2, we can get better performance in terms of image quality. And we also have done a clinical review side by side. And in like majority of the cases, it's equivalent in terms of diagnosis part, but also actually better in terms of diagnosis confidence. And there's no artifacts identified from the studies. And so this has been trying to leverage, we try to kind of push this for potential clinical usage as well. And there are several cases for trauma, and to show the enhanced version is actually better, more delineation in terms of certain parts, so we can see, visualize better for better resolution as well. And so I think all this really shows the potential clinical applications for deep learning-based control synthesis, and why it's actually better in terms of quality. So it's people talk about whether there's like quality sacrifice, but actually I think it's key to show it's actually better, because standard care doesn't mean best in terms of quality. It's just always there's a trade-off between quality and cost. And I think here AI, deep learning in general, really trying to renegotiate the trade-off for clinician, so they can get quality and efficiency and actually add value for some maybe clinical protocol where they don't have time to acquire stir, we can generate a better stir. And since that version we show with clinical tests, it's interchangeable to get the same diagnosis decision, and also significantly better in terms of just preserved image quality. And the next one is to apply for vessel wall imaging. It's also deep learning based enhancement, and we lately have presented at ASNR, which is I think just we finished in Tuesday, just today. So basically we show deep learning pseudo-MR based can enhance the advanced sequence like CAPI accelerated contrast enhanced 3D T1 for like neurovascular imaging applications. And I think that contrast enhanced intracranial vessel wall imaging has been really useful to evaluate artery wall inflammation and several other applications. And one of the key sequence here shows using the space is basically a high resolution, like whole brain coverage type of really high quality acquisition. And but it's a trade-off, so it's really routinely can be slow, and it can be significantly accelerated by advanced sequence like CAPI, etc. But it's for direct usage will sacrifice the quality and sometimes have amplified noise artifact, which make clinicians really worried or scared of use because it may generate certain artifacts they don't understand. And the purpose is to really investigate the feasibility of using deep learning to enhance or to denoise the accelerated space T1 with the 3D T1 space accelerated using CAPI already, which can introduce like spatial varying noise. And we really evaluate how the deep learning can enhance it and for clinical applications. And here is a new group of 62 patients outside the training data sets to evaluate. And we sequentially acquired standard care and accelerated versions. And we enhanced the image using our products and the general image enhancement technology, and show the which basically the model is trained on more variety of data sets, and so it's generalizable for this model, and which more important is whether it's really good for clinical purpose. And so there are several analyses we have done for quantitative review to compare a qualitative review to compare across standard care, accelerated version, and accelerated using SLMR to enhance, and also quantitative or semi-quantitative to rate by the clinician on several metrics: image quality, artifact, SNR, which is general quality, but also the lesion assessment for vessel wall abnormality, and also for arterial venous blood suppression, which is needed for clinical applications. And there's just several results quickly go over here. So just first, combining the advanced sequence, which accelerate the scan, and enhanced or denoise using deep learning-based algorithm or products, we can achieve adaptive noise reduction, which I think fundamentally the model has been trained using this specific data sets or the sequence, but it's in general generalizable. And so that's, I think, a lot of generalizability can be further improved, and there's an evolving technology using different model architecture to keep improving it. And so it can solve the adaptive noise reduction issue. And what is more important for clinical is it improves the vessel wall boundary definition, which is really key for clinical applications. And so, and also for like image quality, just because we can reduce the scan time, is actually reduce the chance of certain artifacts like the motion. So it's improved quality in general. And by enhancing with SAT-MR, it can reduce the scan time, reduce the motion artifacts, but also get the quality back as answer back. And we also observe there's improved flow separation that has been helpful for clinical applications, as even better than standard care. And so that we with several quantitative analysis, which shows image quality generally. There's the distribution also shows getting significantly improved and similar to standard care, and artifact is similar level and better than standard care, just because the motion from the lung scan, and also from SNR and lesion perspective is significantly improved from the acceleration and equivalent to standard care. And fundamentally, I think it's just to show it's deep learning-based algorithm that's actually trained on a very generalizable data, validated on very generalized data, can be applied for enhanced advanced sequence that's been more and more kind of introduced to the clinical applications, and to improve scan efficiency without compromising diagnostic quality, and effectively reduce the spatial varying noise amplified by the advanced sequence. And we can really achieve a similar quality compared with standard care. And overall, the quality of delineation and lesion detectability is consistent with standard care. So it's really have a better combination to serve the increasing need of rapid neurovascular imaging. Yeah, I think with that, this concludes the general introduction for 3 papers. I think we have leave some time for Q&A, but in general, I think the general idea is AI can not only like potentially maybe, I think we not talk about replace radiologists, but eventually empower radiologists, automate radiologists. And from the upstream workflow perspective, we really focus on using AI to improve workflow efficiency and serve more patient better. And so for per patient, it's better experience, improve image quality, and from like an image center hospital perspective, eventually is a operation value as well. Yeah, with that, I would like to conclude our talks, and happy to take questions. And this is our contact info if you have additional questions, want to talk offline as well. Thank you. Tan?
Yeah, thank you, Enhao, for the wonderful talk. So for the audience, if you have a question, feel free to type it in the Q&A session. I do have a question about the later 2 papers. I was wondering if it is possible to share more technical details of the method you use, how to emphasize for example, how to emphasize the pathology region, what kind of network, I might have missed it. Is that the Sven transformer you introduced in the first paper?
I think the later 2.1 is not, I think later 2.1 is used, some even use existing product. I think conventionally is a combination of unite plus rest layer plus ResNet layer plus dense layer. So it's more conventional, but I think our tech stack has been transformed from like to transformer or even diffusion model. So we do observe for sure advanced improvement, as we mentioned, using transformer, and we have some work on diffusion models, and we try to also learn from the industry, learn from field on diffusion model as well to applying similar applications. Yeah, to answer that, I think we can share the several papers and conference papers, and generally I think that is it's not transformer based. It's the existing technology. I think the key is to show clinical clinical application, like clinical evaluation, which is going beyond numbers, but really to show like interchangeability that's used directly on like clinical diagnosis.
Yeah, thank you. Yeah, it is awesome to see that image synthesis can be used in the clinical setting, because I personally work in this field. We have questions from the audience. CT and MRI have significant differences in structure. So how will you catch the feature to translation in the future work? They are different from MRI T1 to T2 weight translation, because T1, T2 image has a similar structure from image. Or one more thing, how will you get the data set? Paired medical image is really difficult to obtain. Many publications didn't open the data set to make it available.
Yeah, I think I can take this question. I think it's a follow-up question to a previous PET denoising, where I mentioned that the transformer work that I presented can also be extended to the PET image denoising, while I also mentioned cross-modality synthesis feasibility. Yes, I agree that the CT and MR have fundamentally different features, but people have shown feasibility of cross-modality synthesis using other like unit-like networks. But so I was merely mentioning that transformers can also be applied to such applications due to the inherent nature of the design. So hope that answers the question.
Thank you. There's another question from Benjamin. Thanks for the presentation. For subtle IR, interventional radiology equals to enhance low-dose fluoroscopic images. Do you already have a publication, please? Could we have more details? Is it done with real patient data? How many patients in the training set? And image, how about image resolution? Thank you.
I don't have exact number on my hand, but I do think it's been presented on one MICCAI event. I think maybe a couple of years ago, and we have been collaborating with several academic and industry partners. Also get SBIR grant, small grant on top of this. I think in generally it is a different model, or kind of we are still exploring the model as well, because it's I think the fundamental is to making sure it's also run efficient as possible. So there are a lot of model we kind of try to use leverage from the industry, like the real-time video enhancement, and to also capture the like different dimension of the, like both spatial and temporal information. So there's one, I think one like MICCAI, I think it's paper, workshop paper that we published, but still a lot is kind of, I think we also have a patent, but maybe not today, but I think we can for sure share a lot more info. Yeah, but I think that I do feel it's a additional challenging to making sure the model run faster enough. Yeah.
Yeah, thank you. We have more questions. What are the best metrics to measure image quality?
Sorry.
Is it for a specific application that is being asked, or so I will. So in general, for the missing data imputation, we, as I mentioned, we used PSNR, SSIM metrics, which are pixel-based metrics, but also the LPIPS perceptual metrics, like I mentioned, which is basically assesses the perceptual quality as measured by a human reader. So these are the metrics we used. So apart from that, we also, like I mentioned, used a proxy metric, which is basically the dice score segmentation to assess, to mimic a clinical setting, and then to make sure that the synthesized image quality is like clinically equivalent. Yeah, so similar metrics were used for the spine synthesis as well. And the video denoising, of course, they were also using similar metrics. I hope that answers the questions.
Yeah, thank you. Yeah, having a downstream task like a segmentation makes the work much more complete and more convincing. We have more questions. Will this method can be extended to ultrasound, as it's more challenging than MRI PET images?
Yeah, I think there's work at Stanford side. We work on using AI to do ultrasound debuggling. There's also, I think, papers, but I for sure feel this just from signal quality perspective, starting like have more signal quality issues, and also from a generalizer perspective, I think it's more variability from different manufacturer for ultrasound. So yeah, I haven't personally done like ultrasound work, but in addition, maybe only there's a Kaggle challenge, right? There are several Kaggle challenge on ultrasound, but I feel there fundamentally there are a lot of works already on using deep learning to improve ultrasound, and yeah, as SATA we haven't have a like product yet.
Yeah, thank you. A follow-up question about the matrix. What are the non-referential metrics we can use?
I'm not sure what the person means by non-referential.
Oh, I guess it's
yeah.
when you don't have a ground truth, right? How you use it. Yeah, I think there's several non-reference, like I think as the resolution metrics. I think we have some have a paper we use that to show resolution, like super resolution tasks. I think there's something like that, and yeah, I think for general, yeah, image quality, I think you can use SNR in general, right? Not PSNR, but SNR, right? CNR, right? That's non-referential. But I feel there's some fundamentally you want to show is for clinical applications, and a lot of clinical applications, you will need the ground truth.
Yes, yes, I agree with this. Another follow-up question about metric. Will this help downstream tasks like segmentation because information is still from the existing sequences?
Yes, yeah. So we also we didn't publish this, but we also tried to include the segmentation as one of the tasks for the transformer to see if it improves the image quality and vice versa. So basically like a multitask model, and we did get some promising results. So basically the synthesis helps segmentation and segmentation helps synthesis. So if that answers your question.
Yeah, thank you. One more question. Thanks for the great and interesting presentation. I was wondering which radiology fields would you see mostly impacted in the near or late future with your technology? Talking in terms of anatomical areas, pathologies, and imaging modalities, which are the next challenges that you are looking into? Thank you so much.
Yeah, I think in generally from radiology perspective, we start with MR PET. They for sure have some reason because my research preset on MR PET, so our model like work at the beginning. But in addition to the data to research at Stanford side, MR and PET is fundamentally the most expensive, inefficient exam. So there are a lot of room to improve. And then we for sure already get into more modalities because MR and PET I think account for around maybe 20 to 25% of all the radiology exams. So there are another 75% that we or the field can improve. The industry will use AI to improve that for sure. I think that's a key trend that's not only on the manufacturer side, from research sides, but also from clinical applications. They're getting more and more adopted using AI to improve, augment. So because for all the radiology exams, clinicians always want a better quality and efficiency. There's like, I think it's kind of it will never be fully satisfied because there are always clinical questions the clinician can ask as well to provide better care. So I think quality and efficiency is a need for different modalities. So I think we are also getting to look into CT because just a huge volume. There are a lot of value. It is not for speed, but for dose, for contrast. So I think for different modality, there are different kind of like clinical need. And I think it's really important to start from clinical needs, not only to start from technical side to develop product. And in addition, I think generally there's I think two trend. If the question about the future like focus, I think one thing is just generally the AIGC or just a generative model, how to combine that the latest model data development and to generate better quality. And I think we have shown several studies. And people talk about whether the consecutive will be quality degradation, but a lot of exam shows actually get better quality by combining information. using generative model. And second, I think, is the harmonization beyond the pixel domain. So we're also working on technology to really harmonize across different kind of modalities or different kind of type of data, because radiology or even radiology report is not only just pixels. There are a lot of informations whose inconsistency are introducing delays in the workflow. So that's something we are working on, like cross modality, cross function, and it's combined with cross the multi-head model, right, or even big model. So I think that's something we are really looking forward to explore more.
Thank you. One more follow-up question about the metric. If the dice score metric is used, is it like you compare the dice scores of the enhanced image using your methods and non-enhanced images?
Yeah, so let me clarify that. So the dice score, by dice score, we mean that we have an automatic tumor segmentation algorithm that computes the dice score of the tumors present, because it's a Bratz data set that we use. So basically we do two scenarios. One is where we compute the dice score on the ground truth and the dice score on the synthesized, say, post GAD, and then compare the, segment the tumor on the ground truth and segment the tumor on the synthesize and compare the dice score. And then we segment the tumor using a set of images with one or more missing sequences and compute the dice score. Where we replace the image using synthesis of our method and then compute the tumor and then compare these dice scores to show that in the missing scenario, the dice score is low, and then in the synthesized scenario, the dice score is restored back to what it is in the original sequence of images. Hope that answers the question.
Thank you. A more high-level question. Curious to know your insight. What is the most fundamental reason that synthesis can work to generate contrast?
Yeah, so basically there has been some biological evidence showing that the multi-contrast data has some complementary information, which basically is not visible to human eyes, but can be used to synthesize the information that is available in the other contrasts. So this is the the biological reason or the premise that makes synthesis work.
Yeah, I think pre-deep learning, there are a lot of work using image to inverse calculate parameter mapping and using that to generate contrast, right? So there's fundamentally on pixel level, there's it's kind of nonlinear mapping, but in a way, it is likely underdetermined with the contrast rate just using Q92 to generate stir. But there are a lot of information you get not from single voxel, which can help to serve the inverse problem better, right? So I think there are several works on different type of contrast synthesis, and just there's a redundancy within the information, and human beings is not as good as we should imagine what a stir looks like from Q92. It's just hard task, but for deep learning algorithm, it's just more straightforward.
Yeah, thank you so much. If there's no more question, that will be today's talk. Thank you so much, Enhao. Thank you so much, Sri, for the wonderful talk. We will, if the speakers permit it, we will publish the video on the YouTube channel. Also, I personally will be the committee chair of the MICCAI Sashimi workshop, which is a workshop that focusing on image synthesis and image enhancement. So if you or any of the attendees are interested in submitting a paper to Sashimi workshop, it will be super appreciated and welcomed. Thank you so much for the talk. See you next month.